We are about to kick off our next portion of the day, and we're going to hear from some hospitals that are doing some really innovative work in maternal mental health. We have one speaker who's going to be joining us, Chris Reines from the University of North Carolina, Chapel Hill. Her program will be shared via PowerPoint, and we'll see Chris's face up on the screen. So we're going to hear from 4 hospitals today. I am really pleased to share that Christine Morton with us here, who is a research sociologist at Stanford University and also with the California Maternal Quality Care Collaborative, who many of you have been following their great work around maternity and hospital work. And Christine, I'd love for you to just talk a little bit more about CMQCC for a moment as well and tell us what's happening there before we turn it over to each of our panelists. We have about 10 minutes for each of them to share their programs. And again, what you'll learn is that they're really leading the way in creating outpatient and inpatient treatment programs in maternal mental health. And we would really love to see every community in the near future, even 10 years would be fabulous, offering these types of resources. We've also asked each of them to complete a survey, which is in your packet. Kelly, do you mind pulling out your survey and holding it up for everyone? We, in addition to sharing their inpatient and outpatient programs, though, we invited them to tell us what the rest of their hospital is doing around maternal mental health. And this is what we're calling the whole mom assessment. So not just body, but also mind, and what trying to plant seeds and what hospitals can do to make a difference in maternal mental health. And we'll take a little bit of time to talk over those results, but we're essentially trying to show you that every hospital, even these really remarkable hospitals that have an outpatient or an inpatient treatment program, don't necessarily have everything, all of these best practices in place to support women and their mental health during this critical period in their lives. So it'll be fun to have a dialogue about that as well after we hear about their inpatient and outpatient treatment programs. So without further ado, I'm going to turn it over to Christine Morton, and please welcome Christine to the stage.
Thank you, Joy, and thank all of you for being here today. As Joy said, I'm from the California Maternal Quality Care Collaborative. We've been in existence since 2007, and we started our work by working with the California Department of Health Maternal Child Adolescent Health Division, reviewing maternal deaths statewide. So we early on were interested in this one? Both of them. Okay. Looking at all causes of maternal death, but we quickly realized we didn't have the skill set and the expertise to really do justice to the maternal deaths due to suicide, homicide, and drug overdose. I see, okay. You can't hear me? Okay. And so we focused for the first 6 years on the medical causes of maternal death, things like preeclampsia, postpartum hemorrhage, venous thromboembolism, sepsis, et cetera. And we're finishing up our 6-year report on that investigation. Going forward, we are going to be looking more intently at the maternal deaths due to suicide, homicide, and drug overdose. And so I've been interacting with Joy and 2020 Mom a lot more and getting to know many of you in the room who have expertise in this area and who I hope to be working with in the future. So with that, one thing that CMQCC has been very good at doing is taking the findings from these reviews of maternal death and turning them into action toolkits that have been implemented at the hospital level. So introducing best practices and protocols around managing hypertension and preeclampsia, for example. And so we've always worked very closely with hospitals. So I'm really excited to learn more about each of these speakers and the programs that they are working at. I'm also going to help keep time so that when it gets to be about 9 minutes, I'll let you know that you have 1 minute left. We're going to start with Christina Reines. Is that the case? Yes. Right? And as Joy said, she is at the University of North Carolina. The bios of everybody is in your packet, so I'm not going to read the entire thing. And I'll let Chris say a little bit more about herself. And then we also have Katie Monarch here from St. Joe's in Orange County, and she can tell you more about herself. We have Dr. Nirmaljit Dhami from El Camino Hospital in Mountain View. And we also have Mischelle Selco, who runs the Huntington Memorial Hospital Intensive Outpatient Program, very close to here in Pasadena. So join me in welcoming these wonderful panelists for today. And we'll start with Chris.
Excellent. And so the first thing I wanted to say is thank you all for asking me to come to this. It's such an important thing that 2020 Moms is doing, and I've been involved with Joy for quite a while, and I'm excited. I'm really sad that I'm not there in California. I would have loved to have been there. There we go. I have to get my Carolina Panthers and my Carolina Tar Heels in there for you guys to see. Because one of the benefits of me not getting to LA was I was able to watch the Panther game last night. So we are going to the Super Bowl. Hooray. So one of the things that I wanted to talk about, first I wanted to introduce myself and let you know a little bit about who I am. I am a dual trained nurse practitioner. I'm trained in women's health and psychiatry. I work out of the Perinatal Psychiatric Program at UNC. I've been with this program for about 10 years. And when I was filling out the survey that Joy was speaking of earlier, it really made me stop and think about the things that we have done with this program in the last 10 years. And these are the things that I really want to talk about today. So as you can see by the screen, in the spring of 2004, we established our perinatal mood disorder clinic with two psychiatrists that were very interested in perinatal psychiatry. They started a 4-hour clinic once a week. Dr. Metzer-Brody was instrumental in this, who was the director of our program, because they had an interest. And with that, we began to establish alliances with our OB-GYN partners because of the referral basis. Because of that, and because, as you all know, screening is hard to do, and a lot of times the OB practices don't want to screen because they're afraid they don't have referral sources or have a way when they detect moms that need help. So by being able to facilitate the referral process, this was great. And OB then began doing universal screening in the OB-GYN offices at their 6-week postpartum visit routinely. This increased our awareness of the issues of perinatal mood disorders. It helped us with psychoeducation around our psychiatric and our OB providers. It also helped us inform the general public about this, so it raised awareness. And because of that, we were able to establish our resident clinic. It was an additional 4-hour clinic. As we did this, we went through and saw, as I'm sure all of you have seen, many, many barriers to the mental health care, especially within the hospital setting. Goodman looked at these back in 2009 as one of the highest ones, lack of time, but also stigma. And we found that to be true. One of the things that women were telling us is that they would much rather be assessed in their OB-GYN office. They didn't want to go to the Department of Psychiatry because there was a lot of discomfort in doing that and a lot of stigma around that. So we looked at forming an integrative mental health program, Dr. Metzer-Brody and I, along with our OB champions, and they agreed to support 50% of a salary for a dual trained nurse practitioner, which happened to be me. And so my job was then to be embedded in the OB-GYN practice. It worked great. I was there, and I'm still there 2 days a week. And the days that we chose were the ones that they had their high-risk management team meetings. So the 30 minutes of the beginning of each day, they reviewed new patients that were coming into the high-risk OB clinic, which was an excellent opportunity for me to be proactive, to help to see patients that had a pre-existing mental health issue, but also to be able to train and to help our incoming residents from OB and the attendings also to understand and feel more comfortable and gain confidence in being able to treat this, or at least recognize it. Part of the strength of this program was that the flexibility of it and being able to provide availability to the OB providers on a regular basis. I was available to them 5 days a week via pager, was also flexible and able to come and see patients on a real-time basis. What we have developed in the last 2 to 3 years is a telemedicine program. Our OB-GYN department received a grant to look at how we could develop care or have care to the outlying clinics, especially around high-risk OB. And they were wonderful enough to include psychiatry in that. And so now we're able to do telemedicine with our outlying community health clinics through a telemedicine with med management and also supportive therapy. As we began to do that, we also realized that we weren't meeting the needs of all the moms, and a support group was what we felt would be helpful with that, especially people who were not involved in the UNC system. We wanted them to have a way, so we developed a perinatal support group. It meets 2 nights a month. It's, like I said, a bi-monthly group. It's open to the community. It's free. We wanted to base it on the Postpartum Support International model of having free, open access support groups for moms. It also provided us another venue to support these moms with psychoeducation and to help them understand where their resources are. Our group's been running for about 9 years now. We have an average of 2 to 12 moms at every session. It is facilitated by a mental health provider, but it's not a therapy group. It is a support group. And what we do is let the peer-to-peer support, because as most of you know, if you've worked in perinatal mental health for any length of time, moms will listen to other moms much quicker than they'll listen to us as providers. There's still that stigma there, but they want to know how other moms got through it. So the peer-to-peer support group has worked very well. From this, we expanded into the community hospital. Our model in OB-GYN worked so well that we were able to expand to one of our satellite community hospitals where the high-risk OB-GYN has started to practice. We started with a psychiatrist there 2 mornings a week, being able to provide consultation, psychiatric consultation. She also did med management. It expanded, and she is there now 5 days a week, and we have a psychologist providing other modalities such as CBT and family and group therapy to help with these moms, in addition to medication or in exclusion of medication. All of this led to the development of our inpatient perinatal unit. Part of the reason as I was going through this to look at how this happened is I really feel like we built a pretty strong infrastructure. And so we had a lot of colleagues and a lot of supporters that were willing to help us with this. We started out with a pilot program that was embedded in our geriatric psychiatric department. And while that worked really well and we found it to be financially successful, we didn't feel like it was working as well for our moms as we wanted it to do. So we were able to champion some of the administration from the hospital and were allotted about $80,000 to develop a freestanding inpatient unit that is restricted to perinatal patients or women of reproductive age. It's a 5-bed unit. It stays full the majority of the time. And the nice thing about this is that we were really able to meet the needs of these moms. As most of you know, general depression and anxiety is a lot different, or can be a lot different, from perinatal mood disorders. There are specific things that are pertinent to mood disorders, one of them being that there's a baby involved, and we want to make sure that we keep the bonding and help support mom in her relationship with her child through lactation, through support and attachment. And so we were able to provide that in our freestanding unit with lactation consultants that are on call. We have hospital-grade pumps. Our nurses are also dual trained. They're trained in OB and also psychiatry, so that we have patients that are both pregnant and postpartum. Our nurses are able to, after a 24-hour period past delivery, they're able to provide perinatal or postpartum care for moms that are transferred from our OB hospital or women's hospital into our perinatal unit. You can see from the slide that we offer individual and group counseling. There's also behavioral therapy. We have a spirituality program. We also offer art therapy and relaxation. We have a wonderful RN who is also a certified yoga instructor who helps with meditation and helps with mindfulness, giving patients the tools, moms the tools that they need. What we realize is that people can't stay in the hospital until they're completely well. From an insurance standpoint, nobody's going to pay for somebody to be inpatient that long. So what we wanted to make sure that we did was provide the programming and the tools that these moms and these families needed when they were discharged from the hospital that would help them continue their healing and continue their wellness as they left. It has been a successful program. We have about 100 to 120 patients a year. I talked to Dr. Mary Kimmel, who was our medical director, and that's split about 50-50 with postpartum and pregnant women. This is an example of some of the disease processes that we see. One of the things that I feel is important that we did was develop the infrastructure and bring in a multidisciplinary team that understands the importance of supporting women throughout their lifespan, but looking at it from a holistic perspective. The benefits of our program have really allowed us to have outreach. We've been able to expand into the outlying communities, help our OB and our PEDS. We now have a nurse practitioner that is embedded in PEDS also. And then looking at the survey we have from our inpatient program and from our women's hospital program, a lot of the nurses and the lactation consultants and social workers have come through our training and have been able to benefit from us having a perinatal program in the hospital. This is just a little bit of what we offer. These are my collaborators. And this is my information that you can get a hold of me if you need me. Thank you. Any questions?
The question is, do the babies room in with the moms?
The babies are allowed to be with the moms on a very liberal schedule. They do not room in. And the reason we can't do that is from a liability standpoint. When we look at the mother-baby units that were very popular, or still very popular in Europe, what they do is they admit the baby and the mom. And so from a liability standpoint, they actually have a staff to take care of the baby also. It's just not cost effective to do that here in the United States. But we do allow the baby to be on the unit anytime as long as there's another adult with the baby that can be responsible. And so moms are allowed to have the babies 24 hours a day if we have another adult that is there with them.
Okay, we have another question back there. The one question is, what is the cost of the, quote, free support group that you provide through your hospital? And second, do you take Medicaid patients?
We do take Medicaid patients. To answer the first question, the support group is completely free, and perinatal, the mental health providers that run that donate their time, and the office space where we keep our group is also donated. So that is a completely free group, completely free. We do take Medicaid. The majority of insurances, especially for our inpatient unit, we do have a pretty good reimbursement for that. Part of that is because we have been the only one for quite a while in the country. Sometimes it's a little bit back and forth, but we do take Medicaid, especially North Carolina Medicaid. We found a little bit of problems with Medicaids from other states, but some of our surrounding states, they have acquiesced and have paid for the program. We do private insurance. We also at UNC have a program called Charity Care. And so we can set up a payment plan for families and moms that don't have the financial support to pay all at once.
Wonderful. So another question from one of our remote viewers is, what are the criteria for admission to the unit?
The criteria is, as with any psychiatric unit, there needs to be some question of safety. It doesn't always have to be active suicidal ideation. The process is that the the psychiatric provider where the patient is then talks to our medical director, and they determine from the symptoms that the patient is having and the severity of the illness whether they are a fit for the unit. In the majority of psychiatric hospitals, there needs to be, for admission criteria, suicidal ideation or the inability to keep one safe. And that is what it is the majority of the time, but we do have a lot of moms that just need to come in for medication stabilization that have not been able to get regulated at home, and they need the time inpatient to do that.
Great. Thank you so much. I don't know if you'll be able to stay on with us as we go forward, but next we have Katie Monarch from St. Joseph Hospital in Orange, California.
What we do is we have about 5,000 deliveries at our hospital, and we do screening of all the moms when they come to the Mother-Baby Assessment Center, and we use the Edinburgh Depression Scale. When moms score moderate to high, I send their OB a letter for that 6-week follow-up that she's going to be having, saying that Katie scored moderate to high. If she's having any issues, please give us a call, have her give us a call. And so what I did is I created training manuals for OBs, nurses, and social workers and the moms. And so we did a lot of education the first 3 years. We did a lot. We've trained over 200 OBs, 700 nurses, and about the same in social workers on the signs and symptoms. So at first I thought, oh my gosh, I'm going to have a lot of kickback, because what was the first question? What if she says she's going to harm herself? What's my liability? I don't want to screen. So at first we were screening in the hospital itself. Then we moved it out to Mother-Baby Assessment Center. But what we found is once the OBs bought in to the fact that, oh my gosh, now if mom's crying, upset, it's not going the way she thought it was going, I have someone to refer to. And they love it. They love it. So what I do is I meet with the moms once a week or once every 2 weeks. It's 50-minute sessions. She's able to bring the baby with her. And I do individual counseling with her, basically. And then we also have a support group, and the moms are allowed to bring the babies with them as well to that. And then I do a lot of education in the hospital with the labor and delivery nurses, mother-baby unit nurses, lactation consultants, on what the signs and symptoms and what do I do if I do have a mom that presents. And it was interesting this morning because I was listening to Kylie, and it really broke my heart. I thought, oh my gosh, the hospital experience, and I get asked this a lot, what is the hospital role in maternal mental health? So I wrote this up for our skills day, because we have skills days where the nurses come through, and they learn different skills. So I'm part of that as well. And I said, who am I? What role does the hospital experience play in the mental health of these new moms and their families? I am the first person that welcomes these families into their new life. At a time in her life when nothing's planned to go wrong medically or emotionally, it is my words, my expression, my actions the families are holding on to for a very long time. And I think in a hospital setting, we have to pay attention to that. I play a very important role, not only in my expertise or job title or whether I got my break or lunch on time. It is my delivery, each encounter with these families, that counts. I have a big job. After all my education, experience, years of service, these families need me each and every time. In the event the new mom's experience isn't going as expected, delivery wasn't what she had planned, she doesn't seem engaged, she's anxious, overwhelmed, tearful, lack of sleep, it is I who can let her know there is help. Who am I? I am her OB, labor and delivery nurse, mother-baby unit nurse, lactation consultant, mother-baby assessment center nurse, all of us who have an encounter with these families each and every time. What role does hospitals play in the mental health of these new families? Everything. When I end my shift today, I can leave thinking, wow, I made a difference. And the reason I did that is because I wanted those nurses to know, not just the nurses, anybody, I mean EVS, anybody that goes into her room, to know how important we are. And it is, they are holding on to our words, because I do the therapy with these moms, and you would not believe how many times I hear about the experience in the hospital, whether it went good or bad. And so I thought, oh, I think we need to do a lot of educating for the people who are in the hospitals, because that is their first, you're the first person that they see as a mom. You're the first person who treats her as a new mom. So it's really important. So that's what I do.
You still have 6 minutes.
Oh, okay. We also have a behavioral health unit in the hospital, and we have an inpatient behavioral health, and we have an outpatient, intensive outpatient program. And so I go to the treatment team in behavioral health every morning, so I can hear if a mom's been admitted to the unit, either inpatient or if she's going to be coming to outpatient. The first thing she says to me when I meet her is, "Get me off of here," because she's scared to death, because she's in with a lot of other patients. So that's our goal, is to try to get her out as quickly as possible. I've actually had over 1,800 moms that I've seen, and I've only had to hospitalize about 45. So that's pretty good statistics. And the beauty of these moms is they want help. And I've been in behavioral health for 21 years. This is the first population that gets better. And she just starts crying. She cannot even believe what I just said. And lots of times they think I'm way too happy and they don't want to come back, but once they do, they kind of get it. So it's a lot of cognitive behavioral therapy. I do encourage her to have whoever her support system is come in at least once if there's any problems with understanding what's going on with her. And the beauty of having her come with the baby is you get to see the progression and the change. And I've had moms that literally have not wanted to touch their baby for 6 months and have gone on to have another.
The question is, where is she? I'm just going to repeat for the outside listeners. The question was, where do you identify, or how do you identify the women who come to your program?
Mm-hmm.
At what point in their pregnancy and what point of their hospital stay?
Because of the education, if the OB knows that she has a history of depression or anxiety, he'll send her antepartum, just so she feels connected and hooked up before she delivers. And then we do the screenings 3 to 5 days after delivery. They come to our Mother Baby Assessment Center. That's where we have our lactation follow-up. They check for jaundice and all of, they check the baby, basically. So it's the first baby check there. That's where she's filling out the Edinburgh herself.
Another question back here.
So then one is, because we're in the Inland Empire, could we send a mom out to your program?
Yes, you can.
I can.
Yes,
Does it
you
have
can.
to be Orange County only?
No, doesn't have to be Orange County. And as far as the funding goes too as well, is that we do offer financial aid for moms who can't afford it. So there is a small fee, but if they can't afford it, they just fill out financial aid paperwork. But no, they do not have to deliver at St. Joe's, and they also don't have to be from Orange County.
Question about undocumented women.
They're just the same as me.
Then finally, perinatal. What do you do when you got perinatal substance abusing women?
You know what? I haven't had that come up with me.
So the questions were about perinatal substance abusing women, and she said you don't have those.
Well, I'm sure I do, but I haven't seen them personally come through.
And they do take referrals from elsewhere in the Southern California region.
Yes, we do.
Question. Question over here.
Quick question, Katie, for you. I actually work at St. Joe's. Are you presenting at this skill state?
Uh-huh.
And if we know of a mom pre-delivery, can we refer them to you?
Yes.
Okay, so we give the patient your information?
Yes.
Or you actually reach out and contact them?
I can, either way. You can either give the patient our brochure, or you can just leave me a message on my voicemail and I'll call her. Mm-hmm.
And then if a mom does need, is there anywhere in Orange County that has an inpatient maternal mental health, just specifically? I know UCI has a pregnancy mental health when they're actually pregnant, but do they have any postpartum?
I am not aware of any of our hospitals that have, because there's so few that have behavioral health units anyway.
You have to turn it on. There's a little.
At least in our surrounding area, but I hear Huntington Hospital has a great.
Huntington, but is Long Beach close enough? Because Long Beach does have a few inpatient beds for mothers with postpartum mood and anxiety disorders. They do have a couple inpatient beds at Long Beach Memorial Hospital. I don't know if that's close enough.
And maybe, I'm just thinking, because like the program in North Carolina, I would think that our moms that are like at our hospital in Rush would be, yeah, get me out of here, but if they were in a maternal mental health unit, would be more willing to stay and get help.
Exactly.
We're surrounded by other moms.
Exactly.
versus just-
And the ideal would be to have the behavioral health unit on mother-baby.
Correct, yeah.
That would be
Okay.
ideal.
Great, thank you. We'll now move along and hear from Dr. Nirmaljit Dhami from El Camino.
Good afternoon, everybody, and thank you. I'm really thrilled to be here and to see so many people interested in this field and doing the work that all of you are doing. I did want to let Katie know that nurses do make a big difference, as do social workers, therapists, and I believe all hospital staff. So I am the medical director of the MOMS program, or the Maternal Outreach Mood Program at El Camino Hospital. And our program started about 8 years ago. I remember it because it's as old as my third child. And I did tell my son I would talk about him today. But it's an interesting story of how we got started, and I think that may help answer some questions here for people who are looking to start a program. So about 10 or 11 years ago, this was before I joined El Camino, we had a mom who came to El Camino partial program for help. She had postpartum depression, and we did not have a specialized outpatient program to help her. And I believe that the hospital staff tried their best to figure out what would be helpful to her, but eventually this patient had a very bad outcome and had completed suicide. And that event was really almost like a wake-up call for our department, for our staff, and for our community in general of how we could do something differently to support moms. Coupled with that, we also had a change in our administration, and our CEO, our new CEO, was very, very supportive. His daughter was a perinatal psychologist. So those two things together, I believe, planted a seed in many people's minds on how we can think about doing a program. So I won't go into all the details, but in your package there is a 2-page handout looking like this, and it has the 11 steps on how you can start the program. And these were written by our executive director, Michael Fitzgerald, who basically went about starting the MOMS program exactly in this way. So I know there were some questions about funding. We got our funding from our foundation. El Camino is a non-for-profit hospital too, and we got a little bit of funding from, I believe it was $15,000 from our foundation to start our program. And we had a tiny space at the local YMCA, and our funding initially supported 2 patients, and 1 part-time therapist and 1 part-time psychiatrist. And it has grown significantly since then. We now have our own space. We maintain a census of anywhere between 8 to 10, and we have, of course, a much bigger staff. So how we started our program was we had those 2 events, and then we set up a community task force. But instead of going through the hospital administration directly, there was a very smart move to go through the medical staff. So the community task force included people from the local community, pediatricians, OB-GYNs, psychologists, and psychiatrists. And they did a needs assessment in the community and found out that this service was lacking in our community. They also realized that the hospital had the ability to fulfill this service gap. So after 1.5 years, they collected the data, and then they presented that to the medical staff. And the medical staff approved the start of the MOMS program. Our business plan was then approved by our board, and that's how we began our journey. I do want to also comment on the fact that we really stood on the shoulders of giants. A lot of people helped us in the way, from Rhode Island to UNC to Marseille Society that I belong to. And they have just been instrumental in helping us through each step, each time we faced a challenge. And I think the perinatal community in general is very supportive. And I and we are happy to pay that forward. So if any one of you need help or have questions, please feel free to call us. So MOMS is an intensive outpatient program. We have our IOP 4 days a week, 4 hours a day, and it's based on interpersonal therapy, DBT, and CBT models. We also have grown and about 2 years ago started a support group for dads. So in working with a lot of moms who struggle with postpartum depression and anxiety, I realized I do family meetings with each of my patients once they've been in the program for a couple of weeks. And I realized that I was diagnosing a lot of dads with depression time and again. And a lot of times they asked for help for themselves. So we started a support group for dads, which has been hugely successful and very well attended. And it's also very interesting because we get a lot of collateral information on how the patient is actually doing other than just their self-report and what we observe for the 4 hours that they're there with us. Through the Marseille Society, I was able to get in touch with Neen Galanje. I don't know how many of you know her, but she's really one of the pillars of perinatal mental health in the world. And Professor Lynn Murray from UK, who has basically come up with a lot of models for assessing mother-baby attachment and bonding. And Professor Murray was very gracious. She gave us her scale. So what we do in MOMS is we videotape our patients with their babies when they first start the program. And then we videotape them as they come close to completing the program. And we share both the videotapes with them. And moms are just amazed at the improvement that they have made, that's one. But I think it also confronts a lot of negative thoughts that they have about their own parenting skills and how terrible a mother they are. So it's been a very, very powerful tool. We're still in the process of incorporating more and more strategies and tools, which I can talk later. We also have a medication management clinic in which the patients see a psychiatrist, that's mostly myself, and not all, about 50% of the moms that are in our program do not take medications. And the rest do, but oftentimes the decision about starting somebody on meds or not takes a good 3 to 4 weeks. So one of the first things I learned in working with moms with postpartum depression or even depression in pregnancy is that usually it's their first contact with mental health, so there is a lot of value in patience. And sometimes it takes a patient 2 to even 3 weeks to gather all the information, process it, and then decide that they may be willing to take an antidepressant or not. So, I learned patience from my patients. And we also have, I also do a lot of psychotherapy in my medication clinics. They're traditionally called medication clinics, and I think I'm a dinosaur in that process because I don't do med management only. And I try to really meet them where they are, and it's very interesting in terms of the issues that are important to a mom that are so different from what sometimes is written in the textbooks. I've had patients who are dealing with so much shame, guilt, and trauma. And I'm just surprised at the volume of trauma processing that I end up doing. But I also think it's one of the pillars of the work that we do. Let's see. We also have patients from many different cultures. We live in a very diverse Bay Area. And I do a lot of family work, and it's really interesting to see how the family dynamics of shame and guilt and not recognizing postpartum play out in different cultural settings. Oh, running out of time. 15 more seconds. Okay. So I do want to say that we also offer a mom's aftercare group, which is a free weekly group after they've completed the program. And then we have a community support group, which is also a free group for pregnant women, and it's called the Resiliency Building Group. We've treated 424 patients so far, and we cover our costs, indirect and direct both, with an average census of 5 patients per day in IOP. And in terms of future plans, I'm very proud that I belong to an organization like El Camino because we're looking to develop a center of excellence for women's mental health. And we do have a very significant and a very supportive community, and we do have a lot of philanthropic support that's coming in for that. Can I make one more point? Yeah, sure. So this is what Katie had said, and I do want to second that in my work with women with postpartum depression, anxiety, or psychosis, I have seen that, first of all, I know that it exists. We all know that. But secondly, I'm impressed by the treatability of these conditions. They are easily treatable, they're effectively treatable, and also patients return back to baseline functioning. And many a times, especially for postpartum psychosis, a woman may never have a repeat episode again. So I just want to close with that comment.
Very important. Thank you. Thank you so much. Questions for Dr. Dhami? Yes. Is that Lisa back there? You're going to get your own mic now, Lisa.
So we've talked about wanting a psychiatrist. One thing I never know is how much does a psychiatrist cost? What's the going rate? I can't write a grant unless I know that.
That depends on the part of the country you live in.
California.
So I don't know what the current psychiatry salaries are, but I think they're anywhere in the range of 200K plus. For my role in the program, I can tell you how that works. The program does not pay me anything. I bill for my own services through private insurances. And then the hospital gives me a very tiny stipend to cover my administrative work, which is running our staff meetings. And
oh, this helps. I appreciate it.
so if you want to talk more offline, you could also call me or our program, and our administrators will be happy to help you think through that, or at least give you our thoughts.
Good questions. Yeah, go ahead.
You know, a 10-week program, or is it dependent on the severity of their symptoms?
So the question is, how long do moms participate in the program, typically?
So MOMS is typically a 6 to 8 week program, but I have had patients in the program for up to 12 to even 16 weeks, especially if they're pregnant and I can't find a community psychiatrist to send them to. If they need to do our partial track, then especially if they're stepping down from inpatient, then usually they do the partial track for about 2 to 3 weeks and then step down to MOMS for additional 6 weeks of IOP. And I did want to comment on the dual piece. So yes, if a patient does have an addiction issues along with postpartum, and I've seen them a few times, they're usually not the best fit clinically for the MOMS program because it's just a different set of issues. So this is the good part of having a program in a department of psychiatry and at a hospital, is that I have access to a dual diagnosis program and an addiction program. So, so many a times, especially when we're dealing with opiate addiction and marijuana dependence, I do refer patients to our addiction or dual program first, and then they can step down to MOMS.
Okay, one more question here.
When you mentioned that you want to be a center of excellence, is that a designation like in other specialties, or what do you mean by that?
The question is, what is a center of excellence?
It's a great question because we're working on the definition right now. What we're trying to create is a center for women's mental health with specific focus on perinatal, which will offer clinically appropriate, clinically targeted care. So we want specialized psychiatrists, specialized staff, so staff that have received training in perinatal mental health issues, and then also some research to go along with it. We're working on finalizing the definition and then seeing how we can go about putting those building blocks in place. Because our community has expressed a lot of interest and have supported us through philanthropy in doing it.
Great. Okay, so next we'll hear from Mischelle Selco. She is with the Huntington Memorial Hospital Intensive Outpatient Program in Pasadena.
Hi, everyone. So I'm Mischelle, and I am the lead at the maternal wellness program at Huntington Hospital, and some of my staff is here. A little background about me. I've been working in adult mental health for about 15 or 16 years as an occupational therapist, and for the past 9 years at a general intensive outpatient / partial hospital program at Huntington. Fast forward a few years, I gave birth to a baby boy and unexpectedly had my own severe postpartum depression and anxiety. I wasn't expecting it, and I couldn't find help. I knew from a lot of work and trying to find someone to help me that there were grant programs for people that didn't have an income or very low income. And there were also a lot of therapists and psychiatrists that took cash pay, but they were very expensive. But there was nothing for me with insurance. So I was out of work for about 8 months recovering, basically on my own, in some psychiatric care. And when I came back to Huntington, I immediately went to the director and said, we have to do something. There's nothing in Los Angeles for women that have insurance, and we're falling through the cracks. So the director at the time said, okay, put together a business plan and let's get working. And I said, what, a business plan? So I went back to school and got my master's, and I developed my whole master's thesis on this program and worked really hard to get, what are the best evidence-based practices and how do you get funding for this type of program? And it took about 4 years since we started the business plan that we opened up this past June. So we're also an intensive outpatient program and partial hospital program for women who are within about a year postpartum, or their symptoms started within the first year postpartum. We encourage them to bring their babies with us, but it's not mandatory. We are actually not located in the psychiatric building of the hospital, and we purposefully did that to reduce the stigma and make it more accessible for women. We're actually located next to the breastfeeding center. So it's very accessible, and it kind of normalizes it a little bit for them. Women come on average 3 to 4 days a week, and we made the program hours very short because we know moms are very tired. So they come in at 9:30 in the morning and they stay until 12:20 in the afternoon. Most of our treatment is given in group therapy sessions, but we also have individual therapy, some family sessions when it's needed. Our staff consists of licensed clinical social workers, a nurse practitioner, myself, occupational therapist. We also have an interim medical director, a psychiatrist, and a PsyD-RN. And what the treatment looks like, every day the moms come in and they have their first group therapy session, which is a process group. Then they have an occupational therapy group, and that's when I work with them. And I use a lot of therapeutic activities to help women to manage their symptoms. I see a lot of the moms go through the motions of taking care of their babies, but they're not taking care of themselves. So they might be really focused on making sure their baby gets what they need, but they're not eating. They're not sleeping when they're able to. They're not doing any relaxation skills. They're not taking care of themselves. So I work a lot on that. I also use a lot of crafts and art activities and focus a lot on cognitive impairments that might show up during these depression episodes or severe anxiety. So I work on restoring those skills. We also have cognitive behavioral therapy every group. We have coping skills, working on family issues. Those are the types of things that we work on. And every mother that if they are breastfeeding, they get a free consultation with the lactation consultants. And we're finding that most of the moms need a dietary consultation as well. A lot of them are not eating very nutritious things. We do some med management with the psychiatrist, but we do actually refer our moms out as soon as we know, as soon as they are a part of our program, so that we know they're going to have continued care in the community after they leave us. And we also try to find an individual therapist for them as well. The estimated length of stay for our moms has been about 1 to about 4 months. We are funded by private insurance companies. Most private insurance companies have a contract with our hospital. Haven't had much difficulty with reimbursement. Medi-Cal does not pay for this level of care, unfortunately. And the ways that we're measuring progress, and we're seeing really, really great, miraculous progress. I do actually tell the moms, every time a mom calls me, the first thing I tell her is, you will get better. It doesn't feel like it right now, but you will get better. And there's always a sigh of relief. And moms always tell me when they leave the program, I didn't believe you, but I held on to that. It was so important you told me that. But we do give the moms the postpartum depression screening scale when they're admitted. And then depending on how long with us, we do it every month and we do it at discharge and we take a look at their scores. And we're seeing significant drops in their scores, which has been really great. The substance abuse, women that have substance abuse difficulties with that, we have an IOP PHP for dual diagnosis and also a chemical dependency, and we also have an inpatient chemical dependency detox. So we would refer them there first. Once they're sober, then they could come to us. Any questions for me?
Thank you, Mischelle. We've been asked now that if you have a question, will you go to the mic and talk? My translation skills are not what they need to be, I guess. No. And we can ask questions of Mischelle, and I think what we're hoping for is a broad discussion, ask questions of any of the speakers at this point. Thank you.
So I had a question for Mischelle. Do parents had to have delivered at your hospital in order to receive the postpartum services through you guys?
No, actually, most of the patients we have given birth at other hospitals, interestingly enough. Yeah. We get most of our referrals, moms self-refer, they find us online. That, and then I think the second referral is from pediatrician offices around Los Angeles.
Come to the mic. Can you come to the mic? Thank you.
Different counties, because out in the Inland Empire we're like, we have nothing. So I'd love to figure out, if I knew how many people maybe from the Inland Empire go out to your services at St. Joseph's or to Huntington, because I can't get services out of the car. It's good for me in Grand Rapids. Do you guys keep that kind of data?
I get calls, and when that happens, I actually go through Postpartum Support International and try to find something closer, and there isn't a whole lot. But to have them drive every day out to us in the morning and the traffic's really difficult, so I haven't had anyone from the Inland Empire, no.
Thanks.
More discussion? Yeah, can you come to the mic? I'm not sure if that one's on, but.
It's not.
It's an intensive outpatient program. So on average, moms get from 9 to 11 hours of treatment a week. We do have the option of partial hospital program, which is a minimum of 12 hours a week, but we haven't had a whole huge need for that. I think it's also a lot to ask a mom to come 5 days a week, especially if she's given birth recently and she's still healing.
How do you manage moms' needs that have kids in the NICU, babies in the NICU, with like that separation? Because I know obviously it's like St. Joseph's, there's chalk, and the NICU is not attached to, well, I mean, it's not as easy. You have somebody going to a partial hospitalization program where they're struggling with their own mental health issues, but then they've got a little one dealing with their complicated medical issues. How do you guys work with that?
What we did is we just did education with Chalk social workers to let them know, and their psychologists at Chalk. They're aware of our program. So if they have something that they think the mom would benefit more from our program, they refer them over.
For us, luckily, NICU therapists run groups in our program. Since we've only been open since June, we haven't had anyone that has their baby currently in the NICU that has needed our services. So maybe when the baby is actually ready to go home. And the babies do come to our program, and one of our therapists works on mother and baby bonding and attachment. So that is part of our program.
So we used to have a NICU support group, but it wasn't very well attended because the moms had a lot more things to do. So what we're now trying to develop is having a therapist go to the NICU and work with the mom while she's there with the baby, and then assessing when she's ready to come to our program or partial. Ours is an IOP, so moms can bring their babies. If the baby is discharged from the NICU, that could be done. But I think the more important part is the symptom severity and see if they meet the criteria for partial.
I just have a quick question. For the intensive outpatient programs, have you guys considered using like Ronald McDonald House or having something like that for patients that are not in the area, but it is the closest place for somewhere to go so they wouldn't have to travel so far?
We actually have a Ronald McDonald House across the street, and when we did do the program proposal, we did think about that if moms were coming out from outside of the area, that they could stay there. So that is something we're looking into for the future.
Mm-hmm. So in your packets, you'll find this checklist, I guess, self-assessment of hospital programs, and maybe we could ask the speakers to speak. You don't have a copy here, so you can share that version. Talk a little bit about, so it looks like under training, St. Joe's provides training to all postpartum nurses, lactation consultants, et cetera, and the other two programs are in progress or no. I wonder if you could talk about, maybe for each of you, for your institutions, where you're in progress, what you're planning to do in that area, or reasons why you didn't prioritize that area at this time, or maybe just give us a rundown of that. That might be the best way to go through. So Mischelle, why don't you start?
Okay. So at Huntington, not all postpartum nurses, lactation consultants, and social workers have had a certificate-based training, but we have a very large hospital with a lot of staff. So I think that would be difficult to have everyone, and very expensive to have a certificate-based training. Mm-hmm. However, we are expecting a reproductive psychiatrist to join our team, so I'm hoping that more education will be given to those departments and that we can work more collaboratively.
So at El Camino, this is a work in progress. What I can say is I actually agree with Mischelle. It's very difficult to get a certificate-based training for the number of nursing staff that we have in our mother-baby unit. I think what we're trying to, so the point I want to highlight is that I do believe that educating the community and educating our own staff in the hospital is a constant endeavor, and it's never fully done. I do present grand rounds at our hospital and even in our at the OB department and pediatric department to help educate the physician staff and the nursing staff. But what we're in the process of doing is having one of our postdoctoral interns be present on the mother-baby unit and attend their treatment planning meetings every day and see if they can continue to facilitate that process further. I've also realized that when they have, recently our OB community had a very difficult schizophrenic patient who was acutely psychotic and in late pregnancy and refusing to take meds. And I saw that as a great opportunity to work with them and educate them. So that has actually helped us, help them warm up to psychiatry. And I think that it was a good outcome, and we actually were able to demonstrate how, if we can co-manage a very sick patient with maternity, how that can really be to a patient's benefit. So we are continuing to work, and we'll continue to do so till we get everybody to where we want them to be, hopefully. But yes, it's a work in progress.
And sure. Katie?
And like I said, the first 3 years we did a lot of training out in the community, we did a lot of grand rounds at the hospital, a lot of training of hospital staff. And now I had to come up with a creative way on how to do this, so that's why I'm going to be involved with our skills day now, and so that way that'll help also kind of refresh and go from there. But as far as a formalized certificate training, we have not done that.
Okay, well, the curriculum might have been included in that, but I really want to call out, if we can, a little bit, a question I have about the birth class curriculum and how easy was that to implement in your birthing classes? If you've reached out to other childbirth instructors in your area that may not teach your hospital-based classes, and just some discussion around your engagement with childbirth educators, if you have. Mischelle, do you want to start?
Sure, this is something that we have going in progress. Huntington does have a lot of birthing classes, birthing preparation classes. So I've been in discussion with those educators who are also the lactation consultants that we work with. So we're collaborating to do a little more formalized part of their presentation about maternal mental health disorders, just so that mothers are aware that this is something that could happen.
Mm-hmm.
And we do the same as they're doing there. And then also when mothers come to pick up their "Congratulations, You're Pregnant" book, they also get our pamphlet in from day one there. So it's kind of helpful because sometimes if it's laying around at the house, somebody else may see it.
So we do have a video clip and a documentary that the. So we have a video clip that the women watch after they've given birth to the baby and before they're discharged from the hospital, and I also believe there is a documentary that they see when they come in to register for childbirth at the hospital. So they have to review it and sign and say that they've reviewed the documentary. And then we do have a description of our program as well as the services and symptoms of postpartum depression in the birth class curriculum. And it took time, but I think that once all the OBs realized that we were there to help them, we had a couple of champions, and they were able to get all of this in seamlessly.
Are there questions from the floor about these components of the programs? Or go ahead, you can, it doesn't matter, have any question, that's fine.
This is maybe more of a trauma question than a loss question, but that's part of what we're talking about. I was wondering in your birth classes at the hospitals, if you do this, there's a group called Birthing from Within. It's a childbirth prep class, and they actually demonstrate a cesarean surgery in the childbirth prep class, and they have an assistant come and lay on the floor, and they go through an emergency cesarean and all the steps of that. And it was incredibly powerful, and the reports that these women are giving, the doulas and everyone who's trained in this, say that it really helps with trauma prevention. And I went through it just a couple years ago. I had an emergency cesarean with my first child, and I can really attest to that if I had that preparation, and they showed moments you're going to have if you have this happen, here are the moments where you have agency. When this happens, you can ask for this. When this happens, you have a choice about this. And I'm kind of planting a seed here because it was just phenomenal to see that. So I just am wondering if you do that in your birth classes. That was my question.
I don't think we do at our hospital, but that's a great idea, because if she does have an emergency C-section, that's lots of times is traumatizing to her. And so it takes a while to work past that delivery experience as well.
I will say too, I'm a member of the board of directors of Lamaze International, and having been to some of their conferences in the last couple of years, many Lamaze educators also have a very hands-on kind of, this is what it's going to be like, with all the different tools and equipment that happen, and the feeling of being held down, tied down, and going through those moments of the surgery. And with over 30% of women now having cesarean, whether or not it's truly an emergent cesarean clinically, many women feel that it was, quote, emergent, and so that trauma is there. And so a lot of education curriculum, I think, are moving toward that. Thank you. Cordelia.
Yeah, I wanted to know if you are reaching out or utilizing the doulas in the community, both postpartum doulas and birth doulas.
I've sent letters and brochures to doulas in my area, and that's as far as I've gotten so far. I'm doing all the marketing for the program. It's a lot.
I think I received it.
Oh, great, great.
Yeah. So I just wanted to say that that's a really underutilized resource because the doulas know the women prenatally, and if the doulas are trained, they can identify who's at risk. And then they're also there immediately postpartum, the birth doulas. They're there in the first few weeks after the birth. And so again, them having the training and the skills to recognize and know the resources because they're actually in the home with the woman in her home environment. And then, of course, postpartum doulas come in after the mother's had the baby and stay for many weeks, sometimes months. And again, I think it'd be really critical that you incorporate those type of programs, and also doula programs are not really funded. And I'm just putting a plug out that we need doula programs really to be funded and people to start writing those into your grants because we're well-trained and, already working with the population.
We do, at El Camino, we do have a referral list, and we do encourage some of our postpartum moms most of our postpartum moms to get postpartum doulas, especially postpartum psychosis moms that are struggling with postpartum psychosis. So we do have a network of people that we refer out to for their services. And it's difficult to get it covered by insurances. I know I've written letters and got denied, but we keep trying.
Everybody's working on getting that covered, especially through Medi-Cal and public programs so that low-income women can have access as well, but even just insured people to be able to get that paid for. But nonetheless, if people have the money to pay, I just wanted to say that that's a really important group to include in your team.
Yes.
Okay.
Hi. I know, Dr. Dhami, I believe you were the one that mentioned briefly that there was a case where you had a patient with schizophrenia that everybody sort of collaborated on for treatment. And I was wondering if you guys had any protocols at any of your programs if you're dealing with women who are pre-existingly diagnosed with something like schizophrenia or another serious and persistent mental illness, or if that's sort of a case by case.
There are no existing protocols. What I'm looking to develop is actually a screening tool for postpartum psychosis because there isn't much that I've found, and so that's a work in progress. That's one of my projects when my children are a little older. But there are no specific protocols, but I think co-managing between psychiatry and OB, especially for this patient, resulted in great outcome for her and her family. And I do believe that both the services saw the benefit. I've treated a lot of patients with serious mental illness who've gone on to have children, and also people who have developed serious mental illness after childbirth. And I'm always surprised by the silo system of healthcare and how the communication falls through. So
I work with women with serious and persistent mental illness of childbearing age. And it's a problem I come across a lot in my work, which is when they become pregnant, we have this partition of care now, and it's really hard for my program to communicate with the obstetric providers that, hey, this individual does have a diagnosis of schizophrenia or schizoaffective disorder, but she's also, 24 weeks pregnant. How can we sort of liaise to make this a successful outcome? Because unfortunately for us, it's not a successful outcome most of the time. And so it's just, it's always percolating in my brain. So as you guys are the mental health providers for perinatal, maternal health, I thought maybe there's...
Yeah, one of the two things that helped me with this specific patient, one was working with maternal fetal medicine. So she had a high-risk OB, and the high-risk OB had seen many patients with severe mental illness. So that collaboration was very helpful. And the second part that I found helpful was actually collaborating with the Child Protective Services because they had been involved, and it was really wonderful to watch how everybody came together as a team to help this person take better care of her baby. So those two were the avenues that I tapped into, which I haven't done before.
Okay, thank you.
Mischelle, I have a question for you. You had mentioned that your program is not being paid for. It's paid for by individual private insurers when you bill those patients' insurance plans, but not by Medicaid. Can you elaborate on what the barriers might be?
So Medi-Cal does not pay for intensive outpatient program for psychiatric care. They consider it an elective service, and they don't pay for elective services. So that's something that we deal with in our general intensive outpatient program as well. So they'll pay for inpatient and perhaps some outpatient. I know it's very limited, but they don't pay for intensive outpatient services. That's just one of the limitations of Medi-Cal, unfortunately. Even though it would prevent an inpatient hospitalization, so it would be a lot less expensive for them to pay for intensive outpatient services. So.
Yeah. I wanted to ask Katie a question as well. When you said the hospital administrators had really bought into the program and were really supportive, I'm wondering to what extent your data collection, the data that you have to show the efficacy of your program plays a part. I mean, you mentioned numbers, you have 1,800 patients and that sort of thing. So speak to the value of data. And then
we've been collecting data since the day we started. One, because I had to report out to the funders, and so you have to report out your data with that. And then our program was chosen as a program that the hospital funded, and because we have to give 10% back to the community, and so we were a project for 3 years, and so we had to collect the data with that. So I collect how many moms complete the Edinburgh, how many moms score moderate to high, ethnicity, how many moms entered treatment, how many moms completed treatment, and similar to the, and I use the Edinburgh score at the beginning, and then the end as far as showing that there is improvement with that. We also send data on how many OB letters, how many calls out to moms, and so and that's done on a monthly basis. And it sounds like it's a lot, but once you get it going, it kind of just becomes a system. And you'll be surprised how quickly you can collect that data.
One question? Sure, not a problem. We have time.
How do you collaborate with the community programs like in Orange County, like Moms or that kind of a thing to help either augment what they're already providing or use them as a referral source for after, or that kind of like the family resource centers and that kind of a thing?
Moms was actually part of the beginning of our whole grant, so Pam helped me tremendously in designing the program and getting that going. So we do refer back and forth to each other, and for a long time she was sending her moms who needed the individual intensive therapy to us. They now have an LCSW themselves, so they're able to provide those services. But a lot of it was going out because the grant required so many different things. We had to go out and do the actual trainings for, the Bridges programs, the resource centers, other hospitals, and that's what got our name out there in the very beginning.
Well, I want to thank all of our speakers so much for sharing your time and expertise, and I know that you'll all join me in giving them a big round of applause for their